Now, you say neglected tropical diseases. Who neglected them, and should we hold them accountable? What do you mean by
We
neglected?
should hold all of us accountable. Currently, there are over 1 billion people who are affected by neglected tropical diseases. Over 700 million of those are in Africa. So we need to ensure that the governments actually understand it's a priority. Turkana right now has the highest prevalence of mycetoma in Kenya. Me working in Turkana, I see cases every single day. After a while, I realize I don't have an option for these patients. I start talking. I'm like, I can't be amputating all my patients every single day. My patients are dying. Your voice will be heard maybe nationally, internationally. Then you go to a place where now you tell them, we need to make it a priority.
Welcome to the Med Squad podcast. Now, when I was a child, my dad used to work in an institution where they used to harvest buffalo urine, specifically for research and possibly treatment, I don't know, of a particular disease, which I don't hear too much about these days. Well, on this episode, we're going to be looking at illnesses that you've either never heard of or haven't heard of in a long time, but still affect millions. And of course, I have the wonderful Dr. Bona. Actually, you know, give you the whole context of who you are and what you do with regard to the topic we're looking at today.
So I'm Dr. Bona Nyaoke Anoke. I'm a medical doctor and I'm a public health specialist. I'm currently the head of the mycetoma disease program at Drugs for Neglected Diseases Initiative. This is an NGO that specifically works on neglected tropical diseases.
Now, you say neglected tropical diseases. Who neglected them, and should we hold them accountable? What do you mean by neglected?
We should hold all of us accountable. Everybody's neglecting in terms of the governments, in terms of the people, in terms of the physicians. And we call it neglected. These are tropical diseases, like every other tropical disease. It's not caused by a foreign object. It's caused by bacteria, by viruses, by parasites. But it's the population that it affects. Neglected tropical diseases tends to affect the most impoverished within our communities. Those people who live in remote rural communities, people who are quite poor that do not have access to healthcare. So part of the neglected is that they do not receive adequate preventative and treatment-based interventions adequately, so makes the disease much worse.
Okay. In the neglect part, we've talked about tropical diseases. Are there diseases outside of tropical diseases that are included in these neglected ones?
So currently the ones within the neglected diseases are purely tropical. So what we also rely on the WHO NTD program, the Neglected Tropical Disease Program, has what is called an NTD list, where they list what we regard as neglected. Because as you mentioned, it can be quite hard to specify, because maybe something like mycetoma in your area is the most common. You think it should be neglected, but there is nowhere else in the world that it is there. So for them, we are able to prioritize what is called neglected according to the WHO NTD list, so that we can also prioritize the research and development and funding into those activities.
Also, when it's labeled neglected, now it's prioritized.
Exactly. Because as mentioned, neglected does not specify what type of disease it is. It's just in terms of the resources that have been allocated to it and who exactly it affects. So just to make sure that we are all working with the same neglected list, we tend to work with the WHO NTD list.
Do you lobby for it to be neglected?
Yes, you do.
Okay.
So specifically, I will talk a lot about mycetoma because I work in mycetoma. In 2015, we had, his name is Professor Ahmed Fahal at the Mycetoma Research Center in Sudan. He has been working on mycetoma for the last 30 years. No one else has been working on it. No one else is talking about it, but he had data and to show that it was affecting quite a lot of people. There was a lot of morbidity in terms of people getting amputated because there's no treatments. A lot of people were dying from the disease. He approached DNDI, that's Drugs for Neglected Diseases Initiative, and said, if DNDI is not working on mycetoma, we are drug and development for neglected diseases, we are not working on mycetoma. Who is supposed to work on mycetoma?
Yeah.
So we informed him, of course, as an NGO, we have funders, donors we have to report to. Why we are talking about mycetoma, working on mycetoma, we need also to include it in the WHO NTD list. So in 2016, the NDI, together with the Mycetoma Research Center, approached the WHO, and during the World Health Assembly, we were able to present the case, and in 2016, mycetoma was added to the WHO NTD list.
Yes.
And with this, we were able now to lobby for funding that led us to receive appropriate donor funding to conduct a clinical trial on mycetoma.
Yeah.
Yes.
Not every tropical disease has the privilege of having a Dr. Fahal.
Yes.
Lobbying and working like 30 years is a long time.
It is a long time.
So in general, I mean, there are lots of either research areas you're working on, many diseases. So does it need someone to have a particular passion or a personal contact or a personal...
Unfortunately, it does, because recently we had Noma, which is also another new neglected tropical disease that was added. And this was also from a team in West Africa, even in Nigeria, who worked on lobbying for it.
Yeah.
Because also why we put it as neglected. A lot of these diseases, like right now, if I go to the Ministry of Health and tell them how many malaria cases were there in Homa Bay County in the month of May, they will give me data.
Yes.
It is because malaria is a notifiable disease. If I ask in terms of typhoid or cholera, they have the information because the disease is associated with a certain amount of morbidity and mortality that makes the Ministry of Health have it as a priority so that they ensure at each level of the health system, district level, now county level, are able to transmit that information.
Yeah.
Neglected tropical diseases, leishmaniasis, mycetoma, these are not notifiable diseases.
Yeah.
So if I go to the Ministry of Health and maybe I ask them, how many mycetoma cases do you have? They don't have that data.
Yeah.
It's not because mycetoma does not exist in Kenya, it's because it's not a notifiable disease, because it has not been researched enough, or they do not have adequate data to make it a priority in terms of the health priorities.
Yeah.
So some of those activities are why we also require the advocacy to be conducted by specific people. So if there's somebody in Kenya maybe who works on mycetoma, Turkana right now has the highest prevalence of mycetoma in Kenya. Me working in Turkana, I see cases every single day. After a while, I realize I don't have an option for these patients. I start talking. I'm like, I can't be amputating all my patients every single day. My patients are dying. Your voice will be heard maybe nationally, internationally. Then you go to a place where now you tell them, we need to make it a priority.
Yes.
Yes.
So then, from what I'm getting, it's a matter of like urgency. So if for instance, there's an NTD that may have long-term, like in future, it could really turn into either a pandemic or something like that. Is it going to be given priority, or are we first looking at the ones that are affecting numbers now?
So that's also a good question that a lot of people have been discussing. I remember even the last World Health Assembly this year, they were discussing on whether to change the name from neglected tropical diseases to priority diseases. This would allow also governments to be able to allocate resources to it, because of course also when you talk about it in terms of neglected, you're like, okay, so it means it's not that important. But currently there are over 1 billion people who are affected by neglected tropical diseases. Over 700 million of those are in Africa. So we need to ensure that the governments actually understand it's a priority. And in terms of also morbidity and mortality, we tend to think it does not occur as much. Recently in Wajir, we had visceral leishmaniasis, which is a neglected tropical disease, and marsabit.
The role of it, what?
It's also known locally as Kalaza.
Kalaza,
yes. But the disease itself is called visceral because it occurs within your internal organs, your viscera, and the disease is leishmaniasis.
Visceral leishmaniasis.
Exactly.
That's the last time I'm saying that. Okay.
A lot of people were in Marsabit were actually dying from the disease, and it was spreading. And that is when you realize, even as we call it neglected, we need to be able to prioritize it.
So we need to change the name. Oh, I should that.
Maybe that could be a starting point to put more awareness to it. Yes.
Wow. In line with that, when we come back on the Med Squad podcast, we'll be looking at some of the stigma and myths surrounding NTDs, as neglected tropical diseases. Stick around. This is the Med Squad podcast.
Hey there! Welcome to Zuri Health HQ, where Africa's finest medical minds meet modern care. I'm Yafesi, your host on the Med Squad.
Peer care is personal. It's not just diagnosis, it's direction. From a cough to managing chronic illness, we listen and we lead.
Every symptom has a story. We listen, explain, and act together.
Nutrition is not just about food. It's fuel, it's healing, it's prevention. We help you eat with purpose, for energy, for recovery, and for lifelong health.
We are not just lab coats, we are detectives, and your blood speaks when we translate.
Your mental health is not a luxury. It's your health, period. Whether it's trauma, depression, anxiety, or even wanting to speak to someone, we are here for you.
At Zuri Health, collaboration is our strongest prescription. We connect expertise across Africa to deliver care that is smart, affordable, and people first.
This is the Med Squad. Real conversations, real health, real people. From your inbox to your bedside, we're with you.
Welcome back to the Med Squad podcast as we receive an education from Dr. Bona. It's a serious education because, hey, the things, first of all, visceral leishmaniasis. I
Yes.
learned how to say that.
Yes. There's also cutaneous leishmaniasis
Cutaneous leishmaniasis.
and
How many types?
post-Kalaza dermal leishmaniasis. So they all flow together.
There are 3
Yes.
leishmaniasis.
Yes.
Where? Okay. So the thing is, when it comes to ending, are we trying to end NTDs or just get as much information out there as possible?
So a disease like leishmaniasis, which of course, apart from being found in sub-Saharan Africa, we have quite a lot of cutaneous leishmaniasis in South America, in countries like Brazil, and also in Asia. So it affects quite a number of people. And a lot of work has been done on it in the last couple of years. So we have quite a number of treatments that are available. So the prevention and treatment going together, we are actually working now on leishmaniasis elimination.
Yes.
Diseases such as mycetoma, as I mentioned, apart from working into adding it to the WHO NTD list in 2016, 2017, the NDI conducted with the Mycetoma Research Center a clinical trial on a new investigational product for mycetoma from 2017 to 2021. That was the first clinical trial on mycetoma, and it is currently the only one.
Yeah.
So we do not have data on mycetoma.
Yes.
So we currently cannot even talk about elimination.
Yeah.
With the WHO, we are working to ensure mycetoma is at least prioritized by country, making it a notifiable disease within the health systems.
Something like what I'd mentioned earlier. I'd mentioned buffalo urine, and someone might be thinking, okay, that was random, but it's used in the way they create traps for the tsetse fly.
Yes.
That causes trypanosomiasis.
Yes.
Wow, sleeping sickness.
Yes.
That was back in it was the 80s, 90s that I used to go to my dad's office and this is what they're doing. But I've not heard so much about it. Is it also counted as an NTD?
Yes. So human African trypanosomiasis or sleeping sickness, it is an NTD. It does not affect East Africa a lot. Of course, we have quite a bit of cases, but even with our clinical trials, they're based within the Central African region. We have offices in Kinshasa that actually conduct these clinical trials, but we also have a few cases here. And the good thing, even as recently as 2023, we were able to develop a drug called fexinidazole, which is a treatment that is just oral. Because initially for sleeping sickness, you used to take the medication for which involved you getting injected for a few weeks.
Yes.
And this means you coming from wherever you live to the hospital or staying at the hospital 3 weeks or more. And they used to describe it like you feel that there's fire passing through your veins. So there was treatment, but we saw it was neglected in terms of people were not doing more research to be able to ensure that they're getting adequate treatment. So having an oral drug, you can come to the hospital, get diagnosed, go home with your treatment, and come back maybe just for a follow-up to confirm that it is gone.
Yeah.
So a lot of diagnostics, as you mentioned, of course, is CPE with insects and animals. But then, of course, with the human aspect, there are still clinical trials on NTDs that need to occur. Going back to mycetoma, we usually talk about a lot of R&D needs to be able to happen. We need epidemiological data. I need to be able to tell you in Kenya, this is the prevalence rate of mycetoma. In Uganda, this is the prevalence rate of sleeping sickness. In Tanzania or in Malawi, this is the prevalence rate, which we don't have a lot of that data.
We don't have a lot of that data. So now there seems to be a lot of activity going on. And when it comes to like NTDs, then they're the ones, the TDs that we know and everything. So do you face or have you encountered either stigma or fear with regard to, trying to either do research or advocacy for like this needs to be prioritized and all? Is there any resistance you find or any barriers in the community? Because there's a lot of medical activity happening and I'm like, hey, leave us alone.
Actually, yes, quite a lot. Unfortunately, also part of the neglected part is also on the populations who are neglected, because as I began, they're already poor populations who have been marginalized. And then you come and tell them that this is a disease that is associated with marginalized people, can be associated with poverty. When you talk about poverty, most of the first thing that comes into your head is hygiene. So they assume it's for dirty people or people who are not taking care of themselves quite well. And of course, that comes with now the socio-cultural stigmas associated with it. So you'll find a patient with mycetoma, when you get the prick, starts as a small nodule, progresses quite big, then you have your foot swelling to a very huge size, like an anthill. So it's a big anthill on your leg. It has small holes where it's oozing grains and it's oozing pus. The same thing with lymphatic filariasis, where you have your whole leg swollen. So some of these things which are very physical in terms of being seen, you find for women, it becomes harder for you to be courted or for you to get married, because it's like, where am I taking this? What will I do with you? Will you be able to have children? Will you be able to have this? And if the treatment at that time is amputation, then you're not seen as a valuable member of the society. So unfortunately, with such things, instead of them now seeking healthcare much faster, they hide. And as they hide, it gets worse. And by the time they come actually to the hospital, because it's quite complicated, then unfortunately it's too late. Another thing, because of education levels, literacy rates, we still associate a lot of this with witchcraft, because you hear quite a lot of places. And unfortunately, when you have some of these diseases occurring at a particular place, you'll find hot spots of it. And it's not because of the people themselves, but the environmental factors or other characteristics that make it easier, because maybe within this particular area, we have this specific tree that has the maybe acacia thorn, which now transmits the bacteria or fungi for mycetoma. So people will know those people who live up on that hill, they have been cast, because they're the only ones who get mycetoma. So do not associate with those people, but they don't understand it's those other environmental factors within that specific area that makes them more susceptible. So it's a lot of education that needs to be done in terms of awareness, advocacy, informing them that it is not you as a person, it's not something that you did or something that you did not do that made you get the disease. It is an infection, like malaria. So it's a good thing when you say it's a TDs. It is a tropical disease. It is an infection. It can be treated like the way you treat malaria, the way you can treat typhoid, the way you can treat pneumonia. It's just because of your particular circumstances, you are more susceptible to getting them.
You mentioned education. Now, like we talk about the diseases, if you have someone who is an advocate, having seen the symptoms, having seen the impact in a certain area, they are more knowledgeable about this. But on a larger scale, not everyone is as well trained. Is there also need? Is there a knowledge gap, training gap in terms of
a huge one.
The health workers?
A huge one, yes. Because as I mentioned, also working in mycetoma, the last time before I came to DNDA that I ever heard of mycetoma was in medical school. And that was one lecture out of the hundreds of lectures in the last 5 to 6 years that was done on mycetoma. So even for the medical doctors, we've had cases referred to us where somewhere in Tanzania, a patient was undergoing chemotherapy. Until in the process of chemo radiotherapy, they realized grains were coming out and they're like, okay, maybe that's not cancer. So misdiagnosis is very common. Mycetoma, the same way, once it affects the skin, it enters into the bone. It eats into your bone. So when you do an X-ray, they assume it's a bone cancer. They start treatment on it until somebody tells them, no, this is actually an infection that we could have treated otherwise. So for physicians, there's a huge need to be able to help them diagnose. And also a reason part of why it's neglected, the diagnostic capacity is very low. Something like mycetoma, you need to be able to do a biopsy. Remove the sample, take it for culture or molecular diagnosis, which a lot of our healthcare facilities don't have. So we don't have that proper diagnosis of the patients. Then also in terms of treatment, the treatments or drugs are not being developed adequately. So, okay, I will diagnose you, you have the disease. I don't have a treatment to provide you, which makes it more complicated.
Oh, wow. We're actually going to dive deeper into that, into diagnosis and treatment, and even prevention, if possible, when it comes to NTDs. You're on the Med Squad podcast. We have candid conversations about health and wellness across Africa, and we have a serious education. Stick around. Welcome back to the Med Squad podcast. As we go step by step through what we know as NTDs, do we know them actually? Because neglected tropical diseases are a big issue affecting millions. And we have experts here who work day and night to actually help diagnose, treat, and probably prevent. I mean, you have all the knowledge, the information, but now for the people in, you mentioned Turkana or some of the, some of the far-flung areas where either healthcare is not as easily accessible. Like, let's go step by step. How are NTDs diagnosed and treated? Because as you've said, misdiagnosis is also an issue to around.
So part of the reason, as I mentioned, also why they're neglected, diagnosis is usually very difficult because since very little research and development takes place, we have not developed adequate diagnostic tools because there are diseases like, of course, malaria, where you can have a small finger prick. They put it in terms of the rapid test kit and they're able to tell you that there's malaria. If you go to a disease like mycetoma, as I mentioned, you have to do a biopsy. Biopsy, you need a trained healthcare practitioner who is able to pick the right biopsy, do the local anesthesia, then they take it to the lab. You need a laboratory technician who can actually do culture or histopathology, or a trained person who can do the molecular diagnosis. So that makes it more complicated. There are diseases, NTDs such as leishmaniasis, which has had, I think, better luck in terms of the research and development. And with that, they've been able to conduct diagnostic studies, and they even have a rapid test kit. So it is possible to have appropriate diagnostic tools if research and development actually occurs. So that is what we're trying for all of the other diseases. Things like schistosomiasis, where you're able to get the stool or the urine sample of the patient, and you're able to diagnose it without having to remove blood or a sample of the patient.
So is it the facility or the personnel?
It's everything, because the facility and personnel need the machine. They need the training. If it has not been developed, then they have nothing to work on. Because I can go to a very good hospital, maybe even in Kenyatta Hospital or Nairobi Hospital, and I tell them I have a mycetoma patient. They might have the PCR machine that does the molecular diagnosis. They can have all the culture facilities, but if they do not have a technician who has been trained to diagnose mycetoma, then those machines are useless. Yes. At the same time, you can find a patient maybe in or personnel in Turkana who have the training of it, but they do not have the machines to be able to do it. So all of them have to be there in parallel. And you also need to have had the doctor who actually told you it's mycetoma for you to know that that needs to be looked for.
So in a rural clinic, then what happens? Are we doing referrals there, or
a lot of referrals? A lot of referrals, or patients get frustrated and then just have to go back home
because the resources seem so limited.
A lot of that is already occurring. We have what are called mass drug administrations, which occur in areas where we have a lot of these tropical diseases that are in place. So that has worked in quite a bit in terms of prevention, but also treatment needs to occur at the same time, because even within those prevention campaigns, we have quite a number of people who still miss out that need to be treated. So adequate treatment also needs to be developed.
All right, so looking at the bigger picture, what needs to change for NTDs to become a bigger priority in public health?
We need to understand what are the diseases that are affecting us. We need to understand the numbers. We need to understand the populations affected. We need to understand the health systems that affect these populations. So research and development is definitely a priority. Being able to conduct epidemiology studies, to understand the burden of disease. We need to conduct qualitative studies to understand the social behavioral influences of these diseases and the healthcare seeking behaviors of these particular patients. We need to be able to conduct clinical trials to be able to understand what are the best treatments in terms of drugs. Do we need a vaccine for these particular diseases? Then there's awareness that needs to be done both at the patient level in terms of the healthcare workers and also for the government to prioritize these diseases as part of their health priority agenda, to assign a budget, health budget that is adequate for the R&D activities, for all these mass drug administration, for prevention. Some of these diseases are associated with something as simple as hygiene, making sure that they have potable water, making sure that they have latrines in place, making sure that sanitation is properly kept. So a lot of activities need to be occurring in parallel to ensure that we're able to prioritize the disease and also prevent more people from getting affected by the diseases.
Do you have suspense during the reading of the budget speech, waiting to see?
Yes, every year we are hoping for more, and the good thing, it's slowly increasing. It could go faster, but it's slowly increasing. And we're seeing even within, especially in Kenya, within the Ministry of Health, we have NTD departments that are working more on the activities. Diseases like mycetoma that nobody used to talk about initially are being added within the skin NTD portfolio, within the NTD department. We can be able to tell them that we're trying to make it a notifiable disease, and they are ensuring that it is captured within the health systems that are in place within the counties.
And as you've spoken, the priority is all here. It's very local. So are we still pinning on our hopes on international funding, or are we able to prod the government just a little to take the lead on this?
Yes, so both is occurring because locally speaking, like the work that we're doing with the mycetoma, especially in Turkana, we have the county of Turkana, we have the Lodwar County Referral Hospital that are providing quite a huge support in terms of conducting the studies we are doing there, or epidemiological studies. Internationally, for DNDi, most of our funding is international. The clinical trial that was conducted in Sudan was actually funded from Japan. Yes. The clinical trial on fexinidazole that was conducted in Kinshasa was actually in partnership with Sanofi. So we have quite a lot of international collaborators who allow us to conduct our studies. The studies that we are conducting right now in Senegal and Ethiopia on mycetoma is being funded by the German government. So they are also prioritizing some of our diseases. You will not find visceral leishmaniasis mycetoma in Germany unless it's an imported case, or even in Japan. But they have a research and development priority where they have a specific budget allocated, which includes foreign aid for research and development in other countries. So we're still able to benefit from such activities.
Okay. And how did our friend DJT and his proclamations, did that affect what percentage of research, or what chunk? What's the impact of the US's withdrawal of funding from certain programs?
Unfortunately, quite a huge impact, because a lot of the research and development that occurs specifically on NTDs is from aid. This is donor funding from governments, from philanthropic organizations, because as I mentioned, pharmaceutical companies are not that interested in working on neglected tropical diseases because you will spend 10, 15 years working on a disease for people who will not afford the prices. So that's also another thing. For NTDs, we'll work all these years, then we work to ensure that the WHO puts the drugs in their essential medicines list. Then we work with the national governments to ensure that they can provide the medicine for free.
Okay.
So if you explain that to a pharma company who's for profit, then it becomes difficult. So what we've done with the few pharma companies that we've worked with, like Eisai Pharmaceuticals in Japan for mycetoma, is we get the product from them, the investigational product, the drug.
Yeah.
Then we cover through the international aid the costs for research. So them, it's the in-kind donation of the product, then we cover all the other costs.
Yeah.
And at the end, it's a collaboration between all of us because they understand they're not going to get the profit that they would with their other products. So working with that kind of public-private partnerships has been able to assist us to get some of the drugs that we are currently working on. But we're seeing a lot of governments right now are also trying to allocate some of their budgets for us to do such activities.
Don't they know it will affect them if they come on holiday and we still have those NTDs running around?
Yes.
Well, when we come back, we'll be busting some myths right here on the Med Squad podcast. Welcome back. This is the Med Squad podcast. My name is Yafesi and I have Dr. Bonnet with me and we are having a really, really intellectual discussion. Yes, quite, yes. But in terms of intellect, sometimes we overthink and myths do show up or things that we say based on something we saw in our WhatsApp group or whatever it may be. So one of these statements, I don't know, let me not call them myth, I'll just say truth or myth, but it's a statement. Someone says NTDs, that's neglected tropical diseases, NTDs cannot be cured.
That is false. We have quite a lot of neglected tropical diseases that are cured. Actually, for most of them, as I mentioned, these are diseases, infectious diseases,
Yes.
because usually what we can say are incurable. Maybe it's not associated with a particular infection, but infections as a rule, if I can put it that way, well, there are no rules in science, is that if you're able to find it on time, you're able to diagnose it appropriately, then there is an antibacterial, an antiviral, an antiparasitic drug that should be able to cure it.
Do I, as an ordinary citizen, have access to that list of NTDs?
Yes. So if you Google WHO NTD list, you'll have the full list of all the neglected tropical diseases that are classified by the WHO. But of course, more advocacy is always happening to ensure more diseases are added to that NTD list. Yes.
That's good. See, instead of scrolling on TikTok, go scroll the NTD list. All right, the other statement that's made, medicines are always dangerous. Now, who are these people who say these things? Sure.
These are the same people taking Panadol every day.
Yes.
Mara moja, that they will have, they are diabetic at that time or hypertensive, taking antidiabetics, antihypertensives. So we tend to imagine there are other treatments that are different. They're all medicines, they all went through clinical trials.
Yes.
They have all been provided with registration through governmental authorities.
So this statement says medicines are always dangerous. Who comes up with this? Yeah.
So that is definitely false, but I can understand where it comes from because we think of it in terms of, by the time a person is saying this particular medicine is dangerous, they've had a particular person who got a side effect or who died from a particular disease, but it's just a form of information. The same way we're taking Maramoja every single day. Panadol can actually cause a liver damage. And you'll have somebody dying from the liver damage from taking too much Panadol. So every particular treatment, every particular vaccine or drug has its side effects. Does not make it dangerous. It's just for the patient to be able to understand the health risk versus the benefit of the particular disease, making sure that you're following the treatment regimen and dosage as appropriate. And in the same way we look at drugs, we'll say, okay, why are you looking specifically at poor populations, neglected populations? It means the drugs are not appropriate. That is usually false because they'll assume we are doing those dangerous clinical trials because they do not have the particular information about it. But the same way you're able to use your Brufen, you're able to use your antihypertensive, you're able to use your anti-diabetic drug, you should have a patient who has access to treatment to this NTD drug. And we make sure that the regulatory, the ethical considerations that are put in ensuring you have a cancer drug or you have a diabetic drug is the same way that a patient with mycetoma will have access to this drug.
Okay, so this final statement, I would call it truth or myth. If you don't see worms, if I don't see worms or skin changes, no problem, I'm fine.
So that is false again, but also it depends on the disease. And unfortunately, that's also one of the reasons why a lot of patients present quite late. Because going back to mycetoma, you have a thorn prick, you have a nodule, just a small swelling. It's usually painless. You also have to look at the population that you're looking at. Because if it was you, I'm sure if you had a mound on your hand right now, tomorrow you'll be in the hospital. I want ultrasound, I need for it to be checked. Think of this as a farmer in West Pokot. Think of it as a pastoralist in Turkana. A nodule that is painless. Will it prevent him from taking his animals to go eat grass on the other side of the county where he needs to go by this particular time? So the situation in which these populations are in also affects them in terms of timely recognition of their symptoms and also asking for treatment at the correct time. So it's being able to provide awareness, educational campaigns to tell them, while that nodule is still small, go to the hospital. When you talk about skin and worms, that is specifically for fungal skin infections or intestinal worms. It does not mean that your liver is not affected. Your liver, apart from maybe having jaundice where your eyes turn yellow, you will not find it on your skin unless it's a baby where they turn yellow or something like that. Something like leishmaniasis, you'll see a baby with a swollen tummy because they have their splenomegaly, their spleen has become large. Just because their skin is clear and they see the stomach is big, they assume, oh, maybe it's just eating well. But if you realize the legs are also not growing big, but the tummy is growing big, then you need to be able to look at a patient. Or if I see my child or an adult, they look healthy, very well kept and everything, but they keep on dozing off in class. They're walking around, they fall asleep any particular place. You need to be able to start thinking of diseases like sleeping sickness and not just looking at the person as is, because that is the brain that has been affected. Their stomach is still working well, so they're eating well, they look healthy, but their brain is being affected. And we used to joke about in sleeping sickness in school. When you see somebody sleeping in class, you're like, they have sleeping sickness. Sleeping sickness actually leads to seizures. It actually leads to brain death, and people actually die from the disease. So these are very serious diseases that we need to be able to recognize quite early and seek treatment, and not assume all of them are placed within one particular blanket of signs or symptoms.
So then, what is more effective in the community? Are we looking at health education campaigns or free drug programs? What is more effective?
I always say they all go together, because for them to come and get that free medicine, they need to know what they have to start with. And the government needs to know how much medicine they're giving. And from the research and development aspect, we need to ensure that we're giving the correct drug. So they all need to go together. We need to have health education campaigns within the communities for the patients to have early detection, to understand what they have. We need to be doing training for the healthcare workers so that they can properly diagnose the patients. We need to be talking to our governments, to all the people in healthcare, doing healthcare policies, to be able to ensure that we are ordering the correct drugs, and all the access and logistic aspects of making sure the drugs are in the right place are occurring. And with that, I believe we can be able to look at prevention, cure, and even elimination of those diseases.
Goodness, you summarized it so well. So I was even going to ask if you can give a practical message or aspect. Okay, not from the professional side, now for the either the health receiver. Are they called health receivers? They're healthcare givers and healthcare receivers.
They are receivers.
Yes, the receivers, the patients.
Yes.
So with regard to NTDs or with regard to their own responsibility?
I think the onus falls on us as healthcare practitioners, as people who have the voice. So having a space like this this is already a health education campaign. Hopefully there's a patient somewhere who could have the disease, has a family member with the disease who can hear this and say, oh, this sounds familiar. Maybe they should go and get checked out. Who have this platform to be able to talk about with people who make policies, to be able to make changes, so that we have all these health education campaigns. We make sure that for medical doctors within the hospitals, they have more than one lesson on some of these NTDs, so that they have a greater idea on the impact that they could actually make in terms of looking at these particular patients. So having the patients know that these are diseases that are curable. They are infectious diseases, but also understanding the space from which they're coming from. Because I can be telling you to travel 50 kilometers to go to a healthcare practitioner so that they can diagnose your disease. You are the one who's taking the animals out to eat. You don't have a nanny. You don't have somebody else to help you. You have children. You have cows that need to be milked. You have, so understanding where these particular patients coming from, understanding their circumstances, means that we need to be able to put all these things in place. Of course, patients who are living in poverty, when you're telling them you need to go to the hospital on time, but knowing that they do not have the facilities to ensure that they do, because their work to be able to get the daily subsistence means they have to be in the farm every day. It means they have to be taking the animals out to pasture every day. They need to be taking care of their children. So telling them to go over 50 kilometers to go to a health care practitioner for a painless nodule might not make the biggest sense to them. But also letting them understand that if they also take too long before actually seeking treatment, it gets worse. And that will make it even worse for you. Now you'll have to be hospitalized in that same hospital, making you stay away from your family, from your animals for another 3 to 4 weeks, or even months, depending on the treatment that you have to have gotten. Having the healthcare practitioners also understanding the disease quite properly, making sure they give proper diagnosis. Because if you go to a hospital 1-2 times, they keep on doing tests, they're not telling you what you have, you lose hope in that. You stop going to that particular hospital because they don't know what they're doing. So you go to where they know what they're doing. Then finally, also making sure that the governments are prioritizing research and development, specifically on neglected tropical diseases. They're passing policies which are adequate and which can be implementable in these particular areas, and making sure that there are resources in terms of healthcare practitioners, diagnostic capacities, and treatments to ensure that these patients have access to treatment. And then finally, just for us, being able to raise awareness, advocacy, not just because it will not affect us or it is not affecting us at this particular time, does not mean we should not talk about it. So this is a very good forum for this.
Wow. And that's what this platform is for. It's the Med Squad podcast. Now, we can give you the information, and that's a good thing. But what you do with it is what determines whether or not this has an impact in the healthcare sector. In Kenya, in Africa, please share this episode. At the Med Squad Pod, those are our handles for you to follow. But please engage in the healthcare in the country and the continent, because, well, it's you and I. We've said this before, numbers don't get sick, it's people who get sick. And your actions determine whether or not we prevent those sicknesses and get NTDs recognized as they should.
Yes.
See you next time on the Med Squad podcast.